Thank you for your excellent presentation. We look forward to hearing more during the panel discussion. Our next speaker presenter is Jennifer Ballentine, who's with us virtually. And let's see if we have the slides. Okay. Thank you.
Jennifer, when you're ready, you can unmute yourself.
Thanks. So you didn't hear any of that? I'll start over. Thanks very much for having me. I'm sorry to be there. Sorry to miss being there in person, but very grateful for the blessings of technology that bring me to you remotely. The focus of this presentation is university-based certificate programs as an important branch of the pipeline leading to specialty practice in palliative care. In preparing this presentation, I reached out to the directors of about 25 such programs and managed to connect with 18 of them to obtain detailed information and background. The results are included in a handout prepared for the presentation, which I hope will be made available to you all. It's possible that I missed a program or two and would appreciate any feedback or additional information anyone has. First, I need to start with an important distinction. About 9 times a day, our customer service folks and relationship managers take pains to distinguish certificate program from certification. Simply put, a certificate program is a course of study, generally in depth, related to a particular discipline or topic. Such programs are generally approved by educational accrediting bodies, and participants earn academic credits or continuing education credits. Certification, on the other hand, is an earned credential in a particular field that demonstrates mastery of a certain body of knowledge and skills and sometimes experience. Certification is earned by passing an exam, or sometimes submitting a portfolio of education and clinical expertise for approval. In some cases, the certificate programs are designed to prepare students for certification based on the content of the course or the number of academic CE credits earned, but they do not themselves confer certification. For those of you not familiar with the CSU Charlotte Institute for Palliative Care, here's just a brief introduction. We were founded in 2012 as an initiative of the statewide California State University system, specifically focused on workforce for the palliative care sector. Our mission is to increase access to and awareness of palliative care by educating current healthcare professionals, future healthcare professionals, and building community awareness and advocacy. Our course catalog spans palliative care and case management, and we've worked extensively with individual students as well as organizations. Our small staff has managed over a few short years to partner with about 1,200 healthcare organizations and train 12,500 palliative care clinicians across all disciplines. So to set the university-based certificate programs in context, I'll just kind of briefly lay out the rest of the specialty preparation landscape. As you can see from this, and as Dr. Kamal just noted, the physician fellowships, we only have about 157 sites at the moment, comprising 403 slots. And at this rate, it's going to take about 45 years to close the gap between the number of physicians that we have and the need that is out there. There are fellowships for APRNs and for social work, although these are typically not required. And there are 2 relatively new interprofessional master's programs in palliative care, one at the University of Colorado and one University of Maryland. In terms of university-based certificate programs, in the next couple of slides, I'll give a brief summary of the information gathering I did. Several of the programs turned out to be specifically geared toward primary palliative care, so they're not included in these charts, but are in the handout. Arguably, all the interprofessional programs could be characterized as mostly primary palliative care. By being interprofessional, they don't go too deeply into the discipline-specific clinical skills, but unless that was their stated focus, I've included them here. A few general observations about all of these programs. Almost all confer academic credit rather than continuing education hours or credits, and they charge academic tuition. Most thus enroll one cohort per year of about ranging from 6 to 30 students. Almost all require an application, sometimes to the relevant nursing, social work, or graduate studies school. However, most are accessible to people not otherwise enrolled in the university or school. Most are online or hybrid, in which some of the course material is online, but then there is an in-person component of some length. Each has its particular flavor or special features based on the program's goals and perceived needs. For instance, the University of Washington Interprofessional Program emphasizes palliative care program design along with communication. Smith College's social work certificate features months of mentorship and advisement, and our APRN certificate doesn't require an application, could be completed in 9 months, and emphasizes real-world skills and nurturing nurse leaders. So there are about 6 interprofessional programs and 5 discipline-specific programs for NPs. In the other palliative care team disciplines, social work is best represented with 4 programs, 2 in the West and 2 out East. Unlike the nursing and interprofessional programs, most of these offer CEs, continuing education credits, rather than academic. For RN, post-BSN, or post-MSN nurses, there are just 3 programs available. Spiritual care has the least representation, and I'm kind of hoping I just missed finding some other programs. I did not, for instance, rigorously scour seminary offerings or CPE programs. To my knowledge, we have the only university-based certificate for chaplains. In the handout, I've included information on 2 other non-university-based certificate programs from the Healthcare Chaplaincy Network and the Chaplaincy Institute in Berkeley, California. To my knowledge, there are no certificate programs for physician assistants, perhaps in part because there is not yet a hospice or palliative care specialty certification for PAs. I'll just quickly mention too that we have 2 certificate programs in pediatric palliative care, a comprehensive curriculum in palliative care, and an interprofessional core concepts program. I asked the people that I chatted with about challenges and barriers, and they mentioned quite a few. Sustainability, of course, is always a challenge, getting enough students to enroll to meet revenue goals. A number of these programs were launched with support from grants or donations and are now facing challenges in sustainability. A couple others I talked to were or had been on hiatus due to under-enrollment. On the flip side, others had long wait lists or enough applicants to turn people away. Competing priorities for organizations and students make it tough to commit resources and time to education, and education budgets are often the first to get cut when times get rough. In the design of the programs, balancing cost to the student, enrollment goals, flexibility and accessibility, and depth of the content is tricky. Everyone agrees that palliative care is an interpersonal practice with a strong emphasis on soft skills in addition to scientific rigor. Education requires both learning in these areas and application to the clinical environment. However, adding an in-person or clinical component to the educational program significantly increases cost and inconvenience. It's not an accident that the most expensive APRN certificate program is the one that requires 500 clinical hours. Technology helps. All online programs can utilize tech-enhanced features such as simulation and occasional synchronous Zoom meetings to address interpersonal needs, and they can incorporate clinical experience and application from the setting in which the student is already working. The interprofessional programs all struggle with attracting a truly interprofessional attendance. Most are heavy on nurses and physicians, with only a sprinkling of pharmacists, social workers, chaplains, or others. Finally, measuring impact and outcomes is not only a challenge, but a key component of any professional education program. This was one of the features I was most interested in learning about when talking to these programs, was their approach to outcomes and evaluation. Many of you will be familiar with the levels of evaluation: the learning experience of the student, gains in factual knowledge, application of that knowledge in behavior or skills, and impact, longer-term impact on the student or impact on others, for instance, organizations, patients, clients, and the field in general. At the CSU Charlotte Institute, we place a big emphasis on evaluation and are constantly improving our tools to measure effects, shown in blue below each category. All of the programs, including ours, measure experience and knowledge, usually by way of a survey at the end of the course or term and quizzes and tests of knowledge along the way. Of the programs I talked to, plus ours, 12 were launched in or since 2015, and only 3 before 2010. So for many of the programs, data on anything beyond experience and knowledge just isn't available. Of those with more history, only a couple were really looking at real-world effects of the education. But here are a few examples. In our post-course survey, especially for the long certificate programs, we asked students to articulate what changed in their practice, behavior, attitudes, or approach to the work as a result of the course. Our longer certificate programs include an assigned project focused on application of learning, which students must complete. We've also done some impact analyses of student practice change months or years after completion. University of Washington shared with me that about 85% of their students actually implemented the programs they designed in their capstone project. And NYU boasts a near perfect pass rate of the APRN certification exam. Impact is much harder to measure, but arguably the most important goal of education. In addition to our usual instruments, we are working more and more intentionally with organizational clients to identify specific programmatic goals they are looking for from the education of their staff, and then designing an evaluation study to measure it. We've also conducted alumni surveys to assess longer-term impacts, and in each one, 95 to 100% of the respondents report a pass on certification exams, increases in job satisfaction, and increases in confidence. In terms of policy recommendations, in preparation for this workshop, the Planning Committee assembled a good roundup of past recommendations put forward by major reports and policy briefs, which I've summarized here. Pretty clearly, the establishment and growth of these university-based certificate programs are a direct outcome of these earlier recommendations. I think we can agree there's been significant progress made just in the past few years in creating opportunities for specialty training in palliative care beyond the disciplines of medicine. In particular, certificate programs, especially the online or hybrid models, very specifically meet the call for training throughout their careers for all clinicians, without requiring relocation or interruption in employment. As for other recommendations, without regard to whether they are likely or even plausible, here are a few I've thought of and were contributed by my informants. First off, one of the program directors shared with me that a small consortium of faculty program directors have undertaken a Delphi process to identify required and recommended characteristics of interprofessional palliative care programs, and their findings will be published next year. Excuse me. Personally, I'm of two minds about this. Establishing a minimum set of standards might help in establishing credibility and some consistency for these programs, but prescribing what is optimum is probably not even possible. Preserving variety is good. Different students have different needs, and a variety of programs to meet them is not only good but necessary. If we are concerned, as we should be, about the value of the programs to students or organizations, we should have an expectation that the programs can demonstrate that program objectives are achieved and the ROI is favorable. This will likely never happen, but it would be great to have some consistency in standardization of CE and CME requirements across states, and to include specific requirements for palliative care skills among them. As you can see from this table, only a handful of states have any specific requirements in palliative care related skills at all, and mostly just for MDs and RNs. This too is a state-by-state muddle and effort. As Dr. Kamal so brilliantly illustrated, there will never, frankly, be enough MDs to really fulfill the palliative care workforce. Expanding the scope of practice for APRNs and PAs as physician extenders in primary care, specialty care, and palliative care would go a long way down the road to addressing the workforce crunch. Right now, we have a hodgepodge of laws and regulations. This map shows the status of the APRN scopes of practice nationally. The PA map is considerably more complex. Educating working professionals is important, of course, but the future of palliative care and healthcare specifically is in the hands of undergraduates, not only to ensure that all healthcare workers have an understanding of the concepts of palliative care, but to introduce them to the specialty, which will likely lead to more graduates entering the field. Embedding palliative care content into undergraduate curriculum is incredibly challenging for reasons it would take about a day to go into. Creative solutions are required. I know LNEC has done some good work in this area, and we're working on it too. Over the past year, we've been building and piloting a faculty toolkit of grab-and-go resources for faculty in any discipline to incorporate palliative care topics and content into their courses. So far, about a dozen faculty members on 3 campuses have utilized this resource in classes ranging from nursing to kinesiology to anthropology. The CSU system across 23 campuses, nearly all of them with nursing and social work schools, graduates 85% of the California healthcare workforce. And as a result, about 15% of the US healthcare workforce. As we expand these tools and make them available to faculty across the system, it could well be transformative. Other universities and systems could replicate this model in their own states. This, like several of my recommendations, is more a little p policy recommendation, but I'd like to make a plea to foundations to prioritize funding for education. Much of the philanthropic emphasis in healthcare is on delivery of services, testing new models of care, and reaching underserved patient populations, as it should be. But education is the great multiplier of effect. If we are serious about building the workforce we need, we have to support and expand education and training. Likewise, healthcare organizations must prioritize and commit resources to ongoing education and training. This includes time to take the courses, reimbursement or funding for the tuition, and rewards when extra skills and knowledge is acquired. Education is not a frill or a benefit. It's the bedrock of quality care. And of course, as Dr. Kamal noted, pass and fund and implement the Palliative Care and Hospice Education and Training Act. Thank you.